So the first case study is a 67-year-old male who presents with fevers, chills, and confusion. Vitals: temperature 102.9 Fahrenheit, heart rate 128, 86/52, respirations 30, and he's sitting at 90% at room air. Exam: he has coarse crackles bilaterally, and he has a delayed capillary refill, past medical history, type 2 diabetes, and COPD. So for differential diagnoses, I put sepsis due to pneumonia. He has fevers, chills, increased heart rate. He's hypotensive. He has signs of hypoperfusion. He has delayed capillary refill, and he's confused. And he is sitting at 90%, but he does have COPD, so some people can live at 90%, and I'm not sure what his oxygen level is at baseline and if he wears oxygen at home. He has signs of infection, and he meets SIRS criteria with his increased heart rate, his temperature, and his respiration rate. Also, a positive finding is that he has crackles. So he has the risk factors. He's an older adult, and he has diabetes. He has COPD, which increases his risk of respiratory infections. Another differential diagnosis is COPD exacerbation. He's tachypnic, tachycardic. Negative signs: he's hypotensive, and he has a fever, which does not point to an exacerbation. He could also have a viral infection. He has fever, chills, and he's prone to respiratory infections with COPD. Negative findings: he has a high fever, and he has crackles. So I would get a viral swab to rule that out. Another diagnosis: urosepsis. He presented with confusion, fever, hypotension. He's tachypnic, tachycardic, however, he has crackles. I would check his UA and get a urine culture, see if his UA is positive for nitrates, any presence of white blood cells with a clean catch sample. He has the risk factors. He's diabetic, and he's an older adult. However, there's no reported dysuria, urinary urgency frequency, suprapubic pain, or flank pain. So I say it's most likely sepsis due to pneumonia. I would check his lactate, see if it's elevated, and do fluid resuscitation, at least 30 mLs per kilogram, oxygen, nasal cannula, blood cultures, potentially a breathing treatment such as a duoneb, and after the blood cultures, broad-spectrum antibiotics such as cefepime, followed by Vanco to cover gram-negative and positive pathogens. If he remains hypotensive, he may need norepi to keep his MAP at or above 65, get a chest x-ray, and then still get that UA and urine culture to check for another source of infection. The second case study: a 59-year-old female presents with crushing substernal chest pain, radiating to the left jaw and arm. She's nauseated and diaphoretic. Vital signs: 92/60, heart rate 110, respirations 24, risk factors: hypertension, obesity, 20-pack year smoking history. I said an MI, chest pain radiating to jaw and arm. She's diaphoretic, nauseated, and women can have atypical presentations. She has the risk factors for it, and I would get an EKG that could show a STEMI and draw troponin, see if that is increased to show a STEMI, and then if she had increased troponin and did not have an elevated ST segment, then that would be a non-STEMI. And if she had a normal EKG, normal troponin, then that would be unstable angina. I also put a PE because she's tachy, tachypnic, diaphoretic. She has chest pain. She has the risk factors. However, it's unknown what her saturations are. It's unknown if she's had surgery or has been immobile for an extended period of time. We're unsure if she has any tenderness or redness in her calf, and does not mention pain during inspiration, just crushing pain. I also put aortic dissection because of that severe chest pain, jaw pain. She's hypotensive. She has the risk factors. I would check her blood pressure on both arms. No mention of neurodeficit or abnormal heart sounds, no mention of tearing or ripping pain. That can be ruled out by getting a CTA. I'm most worried about a STEMI due to the crushing pain radiating to her left arm and jaw. She has the risk factors and her vital signs are worrying. I would get an EKG, troponin, give 325 of chewable aspirin, not nitro because her BP is soft. We're unsure of her saturation, so I would place her on 2 liters nasal cannula and give her morphine for pain. If a cath lab is available within 120 minutes of presentation, then transfer her. If not, then start her on a fibrinolytic therapy with heparin. The third case study, a 72-year-old male is brought to the ED with sudden right-sided weakness and slurred speech. That began 1 hour ago. Vital signs, blood pressure 178/94, heart rate 88, respirations 18, past medical history, AFib, hypertension, no history of seizures. I put ischemic stroke. He has the past medical history of AFib, hypertension. He has right-sided weakness, slurred speech. He's an older adult. So I would get a head CT. Hemorrhagic stroke, neurodeficits, negative findings. He has no reported headache, altered mental status, or nausea, vomiting. Another diagnosis is aortic dissection. He has the neurodeficits, but there's no reported chest pain or ripping, tearing pain. He can get a CTA to rule that out. Migraine with aura because he has the neurodeficits, and that a negative finding is that it happened an hour ago and it persisted, whereas auras normally resolve within 20 to 30 minutes. We're unsure if he has a past medical history of migraines. A TIA because he has neurodeficits, however, they are transient, so I would get a head CT to check for an infarction. Also hypoglycemia because he has neurodeficits, however, that could be checked by a point of care blood glucose. So the most likely diagnosis is an ischemic stroke, past medical history, the time course, and presenting symptoms. I would check his saturations, complete blood count, head CT, coags, get an EKG and troponin to look for cardiac ischemia, as well as blood pressure management with labetalol, so that his blood pressure is not above 185/110, and he's within the time frame at 1 hour. So check for any contraindications for TPA.